Chairperson and the panelists, and I will disclose that Dr. Fawaz Bardouli make my talk very difficult because almost he covered everything that I want to talk about, and I need to delete some slides. Maybe I'll ask his help in between just to give some interpretation for some of the OCT images. But in the two cases that I'm going to present today, I'm going to focus basically on approach to calcified lesions and calcified nodules, which is already covered briefly. So I'll not bombard you with like algorithms and theories. I'll just go to real life cases. I don't have any disclosure. First case, this is a 56-year-old gentleman with history of hypertension who presented with exertional angina. He had CAG in another institute which showed minor disease in the left main, heavily calcified tight stenosis in the proximal LAD, large OM, and OM2 medium caliber has 70% stenosis, proximal 70% stenosis. He was discussed in the heart team meeting, and the patient himself declined CompEdge. So that's why it was planned to do BCI of the RCA and LAD in another session. So he came for the LAD PCI, and as we can see his angiogram, there is proximal LAD stenosis, and as you can see also from the angio, there is also evidence of heavy calcification. And classical teaching telling us that, if you see calcification in the angio, that means the calcification is really severe. So we tried to just pass an OCT catheter, but we could not. So we just pre-dilate, and then we were able to pass an OCT. And I'll just let it run here briefly. And we'll come to the area of the interest, which is basically in the mid, which showed basically heavy island of calcification, was almost like 360 degree arc of calcium. So this is like full of atheroma, as we can see here, and then we come to the mid, and you can see that the islands here almost 360 arc of calcium. This is like the cross-section of this OCT, and as we can see here, in that tightest area from the cartoon, where the pointer is, we can see correlating in the upper images where there's heavy calcification, almost 360 arc of calcium. So I understand from these images that, doing like regular angioplasty or, cutting balloon most likely will not work. So that's why, based on these images, we decide to go ahead directly for atherectomy. So we went ahead with orbital atherectomy, which was done at 80K RBM and 120 RBM. Now you can argue why you use orbital atherectomy versus rotational atherectomy, and there is nothing wrong in this or that. Personally, I like using orbital. It's you can use one bar size. You don't need to change the other bar size. And the good thing about orbital, it's actually a plate going forward and backward. So this is the beauty about it, and they're saying theoretically the stuck rate with orbital is less than rota because of that reason. So it can ablate going forward and backward. So after ablation, we just went to another balloon, and there was still wasting a little bit. After that, we need to use a cutting balloon, which was 3.5 at 10, and at that stage, we could see that the balloon inflated much better. We did an OCT again just to see the outcome of our plaque modification tools. And as we can see here nicely, there is good evidence of like plaque or calcium fracture, as well as some dissection. And given that picture, we are happy now to proceed to stent, because most likely the stent will expand and will yield very nicely in this case. So this is what we did. We end up with putting 2 overlap stents and then post-dilated with 4O20 NC at 20 atmosphere. And this is the final result. So basically, as you know, that we do OCT in this case just to see if the stent is expanded well, which is very important predictor for the long-term outcome, as well as if there is any edge, either distally or proximally dissection. And as we can see here, that the stent was really well expanded, almost like more than 90%, with no evidence of any major dissection in the proximal or distal segment. And this is the final angiographic result. Okay. Now we'll go to the case 2. So this is a 69-year-old gentleman with history of hypertension and diabetic. He had history of remote BCI to the circ and distal mid of the RCA. Admitted this time with ACS non-STEMI. So I'll show the CAG. This is the... So he was planned for BCI to the RCA with possible plaque modification and then stage BCI to the circ. So this is his angio, and as we can see, it's dominant RCA. There's heavy calcification from the angio with proximal to mid hazy lesion, which most likely suggestive of a calcified nodule. So given that said, we decided to go from the femoral approach using 7 French guide catheter. And as you can see here, we used a supportive guide, which is a AL, and we proceeded to do an OCT just to understand more what's going on in the RCA. And this is the run. It will take longer time, so I'll just go to the picture. And this segment showing the distal RCA stent, which seems quite okay with some mild intimal hyperplasia. And then we come to the interesting part, which is in the mid RCA. And as you can see nicely here from the page or the images above, this is the classical appearance of what we call eruptive calcified nodule, as Dr. Fawaz showed them earlier very clearly. And you know, like generally speaking, calcium is, although it's bad, but we know it's stabilized the plaque and unlikely to present with ACS. It usually presents with stable coronary artery disease, most of the time of calcified lesion. But in case of eruptive calcified nodule, it's a little bit different because it can present with ACS. So that's the dangerous about eruptive calcified nodules, because you have to deal with them most of the time, you know, with intervention. Sometimes you can play with a stable coronary disease. You said maybe you can leave it for medical treatment, but we decide to proceed to BCI in this case. So given the nodularity of this, we thought that unlikely that will be able to pass any equipment downstream. So we decided to go ahead with atherectomy from the beginning, and we went with orbital again at 80K RPM and then higher speed at 120K RPM. Just few words about orbital. So if you are used to rota, you know it's a picking movement faster, whereas orbital, you need to take your time. The recommendation usually to do it at least 1 millimeters per second. So, you know, just to give that time of ablation of the lesion. So after ablation, we went with ballooning just to prepare the lesion more well. And after that, we were happy and went with the stenting of the proximal and the most proximal part of the RCA. And this is the final result. I'll just pass it faster. So as we can see here that, you know, always follow the algorithm of post-BCI OCT, in which you have to see the expansion of the stent, if there's any malopposition, and again, proximal or distal edge dissection. It's worth to mention that calcified nodules sometimes could be very nasty, notorious. They cannot yield with only one modality. Sometimes you need to combine. I didn't show one case here that we use all the modalities available, cutting balloon, orbital, you know, Obian balloon, and sometimes even with that, you know, the lesion sometimes could be really difficult to yield. So this is the final angiographic result after the 2 overlapping stent. So what's the take-home message, the learning point from these cases? You know, importance of using IV imaging in complex coronary disease. We know now it's class 1 indication in the American guidelines. And calcified nodules can be very challenging, you know, to treat, and many times you need really to use multimodality plaque modification. Thank you very much.
Thank you, Dr.